Hello, my name is Aurelius Robertus Novito with student number 128. I will start with the background. Bipolar disorder is one of many psychological conditions found in patients admitted to a hospital. Bipolar disorder consists of two types of episodes, which are depressive and manic episodes. Bipolar disorder affects less than 2% of the general population. Even so, bipolar disorder can be considered emergency as suicide and severe aggression are examples of its most dangerous complications. Approximately one-third to one-half of bipolar disorder patients has attempted suicide, and more than 15% of those attempts were successful. Bipolar disorder also brought the highest risk of suicide when compared to other mental disorders. Suicide in bipolar disorder also commonly found in the onset of the disorder. The problem is, at onset of bipolar disorder, it is common for patients to not know what they are going through, thus increasing the amount of psychiatrist involvement in that phase, a condition known as underdiagnosed and undertreated. There are still no reports from government officials, but an organization named Bipolar Care Indonesia stated that 1 to 4% of the Indonesian population has bipolar disorder. That is arguably a large number considering in 2019 United Nations has published that Indonesia has a population of over 270 million, which means that over 2.7 million to 10.8 million Indonesians have bipolar disorder. As such, bipolar disorder is stigmatized as a really terrifying and life-threatening disease. Uniquely, not only is it life-threatening for suicidal patients, it is also life-threatening for caregiver facing the severe aggression of the patient. Physical injury may occur in facing patients with bipolar disorder. To prevent injury for patients and carers who are handling the patients, adequate action must be used. Thus, this paper aims to inform about many aspects of bipolar disorder, from its definition to its management in emergency and long-term settings, so caretakers and medical professionals can take appropriate measures against bipolar disorder patients. Now, the problem of this paper are: what is bipolar disorder? How is the distribution of bipolar disorder in the population? What is the etiology of bipolar disorder? What are the clinical manifestations of bipolar disorder? How to diagnose and what is the differential diagnosis of bipolar disorder? How to manage bipolar disorder patients? What is the prognosis of bipolar disorder patients? What are the types of bipolar disorder? And the objectives of this paper are to know what is bipolar disorder, to know the distribution of bipolar disorder in the population, to know the etiology of bipolar disorder, to know the clinical manifestations of bipolar disorder, to know how to diagnose and the differential diagnosis of bipolar disorder, to know how to manage bipolar disorder patients, to know the prognosis of bipolar disorder patients, and to know the types of bipolar disorder. And the benefits of this paper are giving information and education about bipolar disorder and its emergency management, gaining more knowledge about bipolar disorder and its emergency management, and as basic information of bipolar disorder and its emergency management for further research. That's all from me. This will be continued by my friend. Thank you.
My name is Claudia Felicia Limanda with NIM number 19025111058. Today I will explain about the bipolar disorder and the definition. So bipolar disorder is a lifelong mental health condition that is consisted of two main extreme poles, the mania and the depression. When the mania happens, the patient will feel euphoric and full of energy. On the contrary, when the mood shifts to depression, hopelessness and loss of interest will happen. Bipolar disorder can occur multiple times in a year, with or without emotional symptoms between each episode.
Hello, my name is Andrea Ivano with the student digit number of 101, and now I will explain about the epidemiology of bipolar disorder. A cross-sectional study across 11 countries shows that the overall lifetime population of bipolar disorder is 2 to 3%. The prevalence of bipolar disorder type 1 in the general population is 1%, while bipolar disorder type 2 is 0.4%. In Indonesia, the Riskesdas has not shown any data about bipolar disorder, though the Bipolar Care Indonesia community stated that 1 to 4% of the Indonesian population suffer bipolar disorder in the year of 2007. The average age of onset in bipolar disorder is 18 to 20 years old, though some studies found it occurring in later of age of more than 25 years old. This disorder has equal prevalence in both men and women in any ethnicity, and around one-third to half of the bipolar patients attempted suicide at least once in their lifetime, and roughly about 15 to 20% of the attempts are successful.
My name is Brian Garvais name 053. The etiology of bipolar disorder. The exact etiology of bipolar disorder is yet to be discovered, and studies into the illness falls behind that of other conditions such as psychosis. Some of the proposed etiologies of bipolar disorder include genetical factors, neurotransmitter factors, and environmental factors. First, the genetics. First-generation relatives of patients with bipolar 1 disorder are roughly 7 times more likely than the average to have bipolar 1 disorder. Moreover, kids of a parent with bipolar illness have a 50% likelihood of developing another severe mental illness. A genetical study found that bipolar type 1 disorder has a significant genetic predisposition with the ANK3, CACNA1C, and clock genes all being implicated. Second, about the neurotransmitter alteration that has been hypothesized to be an etiology of bipolar disorder. Mania in bipolar is associated with hyperdopaminergic, while depression in bipolar is associated with hypodopaminergic. Reserpine reduces synaptic dopamine by permanently blocking vesicular monoamine absorption and has generally been recognized to cause depression. The third one is the environmental factor, such as past life events that could play a major role in developing bipolar disorder. A study suggests that in 1 to 3 month interval preceding the commencement of a mood episode, such as traumatic events, 20 to 66% of bipolar patients encountered at least one stressful event incident assessed independent of their conduct. Similar results have been obtained from a cross-sectional study in Japan that in individuals with bipolar disorder, depressive symptoms may be tightly tied to depressive symptomatology, health problems associated with traumatic previous experience.
Hello, my name is Shantidee with the student number 142. Bipolar disorder, which practically means two polar disorder, have a combination of clinical manifestations which appear to be polar opposites. Manic or hypomanic and depressive episodes happen in turn with subsyndromal symptoms present in between the major mood episodes. When a manic phase takes place, one can appear to be unusually hyperactive, high in energy, which result to decrease of the need for sleep at night. They talk more than usual in a rapid pacing, showing pressured speech. Their actions are unpredictable and elevation in mood or euphoria is apparent. They like to dress themselves in flashy outfits, though often mismatched, but they're confident in them. All of these often make a misperception that manic phase a happy phase, but no. One would also be easy to get irritated, they might experience delusions and racing thoughts, they find it harder to concentrate since it's very easy to get distracted. This phase usually lasts for a week or longer. Depressive phase is a complete opposite. Lasting 2 weeks or longer, depression is closely associated with feeling sad, hopeless, worthless, and empty inside. They lose interest in activities that bring pleasure, aka anhedonia. Decrease of energy is apparent and they keep feeling tired or fatigued. They find it hard to concentrate too, and there's a change in appetite, usually loss of appetite. Their mind is full of guilty feelings and negative thoughts, which can develop into suicidal thoughts. So, it is very important to take preventive measures and to assess suicidal risk in patients with depression. Thank you.
Okay, first, my name is Gabriel, student number 169. I want to tell about diagnosis of bipolar disorder. And diagnosis can evaluate by anamnesis based on the criteria in the DSM-5. And the DSM-5 classify bipolar disorder in some categories such as bipolar type 1 disorder, bipolar type 2 disorder, cyclothymic disorder, drug-induced bipolar disorder, and bipolar disorder related to the other medical conditions, specific bipolar disorder and non-specific bipolar disorder. In bipolar type 1, if the patient has a manic episode, and this episode may be preceded or followed by hypomanic or major depressive episode, and bipolar type 2 is diagnosed when the patient has a current or previous hypomania episode and criteria from a current episode or history of major depression. And in bipolar type 1, diagnosis requires at least one true manic episode with or without episode of depression or hypomania. In bipolar type 2, there is requires at least one hypomanic episode and one major depressive episode in the absence of any lifetime history in mania. And cyclothymic disorder requires at least 2 years of hypomanic and periodic depressive symptoms that differ from another. In the cyclothymia disorder, neither the full criteria are met for the hypomanic or depressive episode, nor are the periods of normal mood lasting more than 2 months. And this is criteria from the mania episode. There is a period of persistent and abnormally elevated, expansive and irritable mood which lasts more than 1 week and is present most of the day, almost every day. And occupational and functional impairment, there is with or without psychosis and is not relatable to the medication or illicit substance. And in many episodes, there are 3 or more following symptoms, signs, such as inflated self-esteem or grandiosity, decreased sleep, be more thought active, racing thought, easy to be distracted, more agitation, and potential self-harm activities. And in hypomania episode, the mood must last at least 4 consecutive days and be present most of the day, almost every day, and diagnosable when there are 3 or more symptoms of mania present. There is no significant social functioning impairment in occupation and no psychosis, not relatable to the medication, drug, or another medical condition. And in major depressive episode, there is 5 or more symptoms which present for more 2 weeks. There is a social and occupational functioning impairment, and these conditions are not secondary to the medication, illicit substance, or medical condition. And the symptoms is subjective or objective depressed mood, such as feeling empty, hopeless, sad, low, and observation by others that one is cheerful. And there is anhedonia, loss of interest in pleasurable activities. And there is a weight loss or gain more than 5% body weight. And there is a sleep disturbance, such as insomnia or hypersomnia, feel fatigue or loss of energy, feeling guilty and worthless, decreased concentration and inability to focus, and there is a suicide thought or attempt. And in bipolar type 1 and type 2, you can see in this table there is a difference in elevated or irritable mood. Is in bipolar type 2 is often irritable, and the severity and duration of episode in mania and hypomania, the number of symptoms is same and the duration of episode is different. In mania there is more than 7 days, and in hypomania 4 until 7 days, and subthreshold mania less than 4 days. And there is a disturbed social and occupational functioning in mania, and hypomania not severe enough to disturb functioning. And there is a difference in frequency of episode. In mania, more than 1 manic episode, and in hypomania, there is more 1 hypomanic plus 1 more than 1 depressive episode.
My name is Claudia Felicia Limanda with NIM number 19025111058. I will explain about the diagnosis of bipolar in children and teenager. It has the same symptoms experienced by adults, but the symptoms in children and adolescents may have different features that cannot fit into this criteria. Those differences are the debut or the start of the bipolar disorder in a child usually start at puberty or early adolescence, with the nature of symptoms with longer symptomatic stages than the period between relapses. It has a very frequent mixed episode with rare symptom of psychosis. It usually stems from a family history, which is very common here, and it has a high percentage of ADHD as comorbidity. The stability of this type of bipolar disorder is unstable. That's it from me. The next part will be explained by my friend. Thank you.
Okay, so my name is Ada Prabudia Sakti with the student number of 253 and I will explain about the bipolar disorder differential diagnosis. So the differential diagnosis concludes of other conditions with symptoms such as manic. Types of disease that could be misdiagnosed into bipolar disorder are major depressive disorder, personality disorder, schizophrenia, attention deficit or hyperactivity disorder, or well known as ADHD, substance or medication-induced withdrawal, bipolar disorder, mania due to medical condition, and dementia. The difference for major depressive disorder is the absence of manic or hypomanic episodes. Meanwhile, for schizophrenia are mood symptomatology, manifesting in the setting of the thought disorder, only although the mood features are similar to bipolar disorder. Meanwhile, for ADHD, the interval of mania are less episodic and undulate in comparison to bipolar disorder. For personality disorder, they have multiple features of mania, hypomania, and depression as overlapping symptoms with the specific disorder of bipolar and histrionic personality disorder. And also, bipolar can be induced by the use of some substance, resulting in mania and depression. It is needed for laboratory evaluation to differentiate with bipolar disorder. For dementia is a condition of the brain that has symptoms that is similar to bipolar disorder, but it is not a mental health condition. Thank you.
My name is Krishuel Van Yapson with the last 3-digit number is 118. I will continue to explain about the management of bipolar disorder. The first step in managing bipolar disorder is to make sure in diagnosing the patient with state mania or hypomania. Treatment options for bipolar disorder can be given such as mood stabilizer, antipsychotic medication, electroconvulsive therapy, antidepressant, and psychosocial interventions. There are two phases of treatment, acute and long-term treatment. In acute treatment, primary goal is to ensure safety of patient and those around them, because sometimes patient will show some severe agitation, violent behavior, and psychosis which will harm them and people nearby. Pharmacotherapy drugs such as mood stabilizer and antipsychotic can be used. Mood stabilizers such as lithium, valproate, lamotrigine, carbamazepine, and topiramate, and antipsychotic drugs like olanzapine, quetiapine, risperidone, and risperidone. Combination therapy of mood stabilizers such as lithium and valproate with antipsychotic drug is rapidly effective than monotherapy itself. In long-term treatment, the goal is to prevent relapse of episodes. The drug from acute phase must be continued to prevent any relapse. Mood stabilizer and atypical antipsychotic are still used to prevent manic episodes, while lithium, lamotrigine, and quetiapine are also effective to prevent depressive episodes. Other non-pharmacotherapy such as psychoeducation, electroconvulsive therapy, cognitive behavioral therapy, and functional meditation also shown efficacy in treatment of patients with bipolar 1 and 2. Thank you.
My name is Cynthia Susana with the last 3-digit 233. I'll be presenting the prognosis. Bipolar disease in general has a relatively poor prognosis. Several studies believe that bipolar 1 disease has a poorer prognosis if compared to bipolar 2 disease, since it is shown that patients with bipolar 1 disease have a higher rate of admission to hospital than patients with bipolar 2 disease. Apart from the type of bipolar disease, some of these things can also lead to a poor prognosis, such as 1. Dependence on drug, 2. Psychotic disorder, 3. Severe depressive disorder, 4. Depressions between episodes, and 5. Gender, specifically men, because men have a worse prognosis than women. If the patient experiences manic attacks, the patient's condition will worsen, thus making the prognosis poorer. If not treated properly, the patient's negative thoughts could lead them to attempt commit suicide, which can endanger themselves. There is, however, therapy that could be done to improve a patient's conditions. One of the therapies that can be done to improve the patient's prognosis is to use lithium prophylaxis. The use of lithium prophylaxis is reported to improve the prognosis in more than half of patients with bipolar disorder. Thank you.
My name is Stephen Jovi, number 161. The next is type of bipolar disorder. The first is bipolar 1 disorder. People with bipolar 1 disorder may suffer from manic and depression episodes. Depressive episodes are common and usually last for 2 weeks. However, bipolar 1 disorder could be diagnosed from the presence of mania episode alone. The mania episode may last for 7 days, with severe symptoms that require immediate hospital care to treat the patient. The risk factor of bipolar 1 disorder may be related to genetic. It is known that having relative experiencing bipolar 1 disorder gives 7 times the risk to bipolar 1 disorder development than the normal population. The prevalence of bipolar 1 disorder is about 0 to 1% in the whole world population, with similar prevalence between men and women. Most of the patients experience the symptoms at the age of 20 or their teens.
My name is Johanna Glory. My student number is 107. Bipolar 2 disorder is distinguished by its recurring mood of episodes of hypomanic and major depressive episodes. It can be diagnosed when one or more major depressive episodes that last for at least 2 weeks and at least one hypomanic episode that lasts for at least 4 days is present in one's lifetime. The average onset of bipolar 2 disorder is the mid-20s and often begins with a depressive episode, which is why it was not diagnosed as bipolar 2 disorder until a hypomanic episode arises. Genetic and physiological factors are found to contribute to the development of bipolar 2 disorder. Bipolar 2 disorder is found more in females rather than males. However, females are more likely to experience hypomanic episodes with mixed depressive episodes rather than males. The suicide risk of bipolar 2 disorder is high, with around 1 in 3 people reported with a history of suicide attack.
My name is Jerry and my student number is 094. So the third type of bipolar disorder is cyclothymic disorder. Cyclothymia or cyclothymic disorder is a less extreme version of bipolar 1 and bipolar 2. It has mania and depression parts as well, with stable and fine periods in between. It changes from mild depression to hypomania, then going back again. This disorder is unpredictable, which it can disrupt life even though the sufferer can still function in daily life. Cyclothymia can be caused by genetics, pre-neurobiology alteration, and environmental experience. The prevalence of this disorder is 0.4 until 1% in US. For men and women, it is equal distribution and mostly in teenage years and young adulthood. Next slide. Here is the figure to compare between bipolar 1, bipolar 2, and cyclothymia of when it causes mania, hypomania, minor depression, and major depression. Next slide. The last type of bipolar disorder is bipolar disorder due to another medical or substance abuse. Criteria to diagnose substance-induced bipolar is the presence of increased and irritated mood, expansive with or decreased mood in almost all activities, also from history taking, physical, and laboratory examination. The prevalence of this disorder is 0.26 until 1%. In patients with alcoholic use disorder is 40 to 60%. In opioid use disorder is 55%. And for this disorder to cause bipolar 1 disorder, the prevalence is 61%. Substance-induced bipolar can induce mania and delirium. It can also progress to a mixed or manic state. Stimulant usage can trigger mania within an hour after ingestion, and it can cause a depressed episode and can subside within 48 hours. Some other medication can induce hypomania or mania, mixed or depressed state in several days after consumption. The higher doses give the higher risk.
My name is Gabriel Nugradina with student number 193. Conclusion: bipolar disorder is a mental health condition affecting under 2% of general population. Bipolar disorder is identified by manic and depression phase. Some proposed etiology of this disorder is by genetic factor, environmental factor, and neurotransmitter factor. Diagnosis of bipolar disorder is done by checking anamnesis to rule out other possible conditions with similar symptoms. Management of bipolar disorder is divided by its time, in which acute treatment's goal is to prioritize safety of both patient and people around. while long-term treatment focus on preventing relapse of episode. Last, bipolar disorder generally has a relatively poor prognosis such as dependence on drugs, psychotic disorder, and severe depression. Thank you.